Hi, everyone. Good afternoon. Thank you all for joining in on today's session, which is the second of a three-part series for neurointerventional fellows. This afternoon, Dr. Curtis Given and Dr. Eric Peterson are going to be presenting on acute ischemic stroke cases. This session is intended to be as engaging as possible during this time of virtual engagement. So with that said, there is a call-in line for you that's available to ask any live questions to either Dr. Given or Dr. Peterson. The call-in number you can find down at the bottom of your screen, but it is also 833-818-2718. And before we begin, just wanted to cover a few housekeeping items. You'll see also at the bottom of your screen are some application engagement tools that you can use. And those engagement tools are resizable and movable, so feel free to move them around and get the most out of your desktop space. You can expand the slide area or maximize it to full screen by clicking on the arrows in the top right corner. And you can find additional answers to some of the common technical issues located in the Help Engagement tool at the bottom of your screen. And should you have any questions during the webinar, you can submit them through the Q&A engagement tool. We will try to answer these during the webinar, but if any fuller answer is needed or if we run out of time, we can answer it for you later in email. But do know we capture all questions, and because this course is sponsored by Medtronic Neurovascular, no off-label questions are permitted. But if you do have any questions that are off-label, please direct them to rs.nvoma@medtronic.com. So our first speaker today is Dr. Curtis Given, and Dr. Given is a neuroradiologist at Baptist Health in Lexington, Kentucky. And our second presenter is Dr. Eric Peterson, and Dr. Peterson is a neurosurgeon at Jackson Memorial Hospital in Miami, Florida. So we just have a few polling questions for the fellows who are on today when we get started. So if you don't mind just taking a moment to answer those questions when they come up on your screen. And with that, Dr. Given, I will hand it over to you.
All right. Thank you guys for having me, and welcome to the new normal and virtual education as we're going to see it. So we'll go ahead and get started, and I'm going to go ahead and go to the first polling question, and I'll try to leave 15, 20 seconds or so to answer, okay? It's amazing this is a test of your patience as well, waiting 15, 20 seconds. It's a test of mine, at least. All right, that's an easy one. We should be good with that. All right, so 3/4 first year and 1/4 second year, and hopefully that doesn't mean there's 4 people on. Hopefully that's a really big number that was evenly, nicely dispersed like that. Okay, so the next question is about your specialty. All right. So, 2/3 neurologists and 1/3 neurosurgeons, and no neuroradiologists. I always tell people I'm the old dog, so this may be proven true with that. So next is kind of a question about volume and what's your all's exposure to mechanical thrombectomy. So at your current institution, about how many, rough guess, mechanical thrombectomies would you say you do a year? All right, so excellent. So this will be easy. There's nothing I need to teach you guys or y'all need to learn. That's excellent. No, in all honesty, that's great. And I think that reflects that's a really good reflection of where we're going, that, we're treating more and more strokes, and that's what we should be doing. We should be offering more therapies to these patients. And so that's a very good response there. Very happy to see that. So with that, I'm going to just kind of go through some tricks of the trade that I've learned over the time. And the thing about stroke and really neurovascular in general that I think you're going to see is that what we talk about we did 2 years ago is not what we do today. What we did 2 months ago may not be what we do today, because there's always these new technologies that come out, whether it have to do with access or a certain device. It really is something that this is an evolving field that continues to evolve. And so with that said, there's no one way to skin a cat, so to speak. There are many different ways to solve a problem that all are reasonable and acceptable, but it's nice to know about these different tools and different tricks that you might have when plan A doesn't work. What's plan B? What's plan C, so to speak? And so, I'm not going to go through a big history of with stroke here with you, but for those of you who are interested in the history of it, Mercy devices, kind of paved the way for this, decades ago. I had the privilege of using Mercy devices, and I can tell you I was terrible at it. I did not have very good results with it, but also didn't use techniques that I use today. And so I think that the Mercy device may have actually been okay with different catheters that we have today and whatnot. But with this evolution, do you use a stent retriever? Do you do primarily aspiration? Do you use an intermediate catheter? All of these things, what determines that? And again, this is meant to be an interactive course. So if you have a question, please type it in. We'll try to answer it. Or, in between our presentations, we'll certainly field questions for you. So what determines what technique to employ? Is it randomized clinical data? Often that is, and ideally, everything that we do is evidence-based practice. But again, in such an evolving field, it's very hard to have often evidence-based data, because by the time the trials are published on device X, those are from 2 years ago, and now we're not even using that device. We're using device Y. And so it's very hard sometimes to say that we're, doing everything that we do purely based on randomized controlled trials. Is it physician preference? This is often a big one, is, hey, this is the way I've been doing it forever and I've had great results with it. That's a lot of it. And maybe it's an anatomic issue. Maybe there's a pathologic reason that may alter what you may use one device or a different technique. So this kind of straightforward M1 occlusion. I'm not sure if you all can see the arrow, but a classic kind of right MCA occlusion with very straight cervical anatomy. And so for me, this is like right in my wheelhouse. Full disclosure, I was Swift Prime and the early trials, and again, Mercy and whatnot. So I'm a big balloon guide believer. And so I'll tell you, though, if you're going to use a balloon guide catheter and you're using it with just a stent retriever and no intermediate catheter, you want to put the balloon guide at the skull base. So it matters whether or not this is straight anatomy. So something that has very straight common, very straight internal, I'm just salivating over, because I know I can put an 1/8" balloon guide catheter at the skull base, and I'm going to get a very good flow reversal with that balloon guide catheter to help facilitate the stent retriever. So when we look here, again, diagnostic angio, straight anatomy. This is in the yellow slide here on the top right, the top yellow box. This is the tip of a balloon guide catheter. So I'm putting it that high. That's how high you want it. If you're going to do traditional balloon guide catheter stent retriever technique, this was the stent retriever deployed, pull out the thrombus, good flow. That's plan A. When I see plan A, I'm super happy. There are 1,000 ways to do this case and be very successful with most of them. And so, what you use is, this one's going to be a great case for whatever technique. This is just something that I show. Again, this is the balloon guide catheter being very high, classic M1. I love to put a J-tip on my wire, because when I'm pushing through the clot for a stent retriever case, I know that's going to keep me in a big branch with very low likelihood of going into some small perforator and potentially rupturing a vessel. So we'll see how this video looks. We're not sure how videos are really going to look here on this. So I don't know if this is going to be a real small screen or a big screen for you all, but hopefully you can enlarge it. And this is just a video running. Hopefully it'll run again, showing a J-tip on the wire. See if I can get that to, yeah. Showing a J-tip on the wire that pushes through the thrombus. Again, a very, very safe way to do that. That's just a trick that, you know, it's nothing new. Many people do it. But I think it's a nice thing to remember that that's a very safe way to help reduce the risk of having some wire perforation.
Hey, Curtis, can I jump in and make a quick comment there?
Please do. Please do.
Everybody that's listening, what he just said is probably the biggest thing you all can take away from this thing. If you take nothing else away from stroke on this webinar, just remember what he just said, because all of the risk for a thrombectomy as far as technical errors comes from a perf. And it's almost impossible to perf with a J. I mean, if anyone has pulled that off with the J-tip synchro, let me know, because I don't know how that's physically possible. But, you know, nowadays all of us are being tracked exactly how many ICHs you have post, how many perfs you have, how many subarachnoid hemorrhages you have, and they track you against national metrics. And you can bet your hospital gets those numbers. And if you're off, then they're going to call you in and it's going to be super unpleasant. And all the perfs happen for the same reason. Number one, chasing an M3 and going up over the top, right? So going around the siphon and going to the M1, M2. No one perfs there too often. They perf going up and over the M3, trying to get their system way too distal, or chasing an M3 that they probably have no business being at in the first place. And the second way they perf is by not doing what he just said with the J. They go with a straight wire, and the wire bounces off the clot and ends up subintimal, and you perf. So if you have a perforation where you do your micro run and you're subarachnoid, it's a technical error and you screwed it up. And doing it the way he just described will fix about 95% of that.
All right. So, again, put that in there. I always try to throw that in because, again, that's learning from my mistakes. If nothing else, we can offer that and tell you all, you know, you don't have to learn the hard way. Learn from our mistakes. This is another one. So this has a almost a 90-degree little kink here in the origin of the internal with a supraclinoid carotid T type thrombus. So when you consider this, consider doing a thrombectomy on this case, the question is, can you get the balloon guide catheter to the skull base? And I'll say the majority of times, I can steer the Berenstein catheter over a glide wire, leave the Berenstein or any whatever hockey stick type catheter you have just sitting in the turn of the Petrus. We do exchanges with all of ours, so we're very facile at doing exchanges with just a Rosen wire, and then put the balloon guide catheter at the skull base. But if you couldn't put the balloon guide catheter at the skull base, then we would start talking about kind of plan B. Do we need to do an aspiration? For me, plan B, do we need to do some sort of a Solumbra or fast technique? But again, here's on the bottom, you can see we've got the balloon guide catheter all the way to the skull base. Here's a 640 solitaire deployed, pull out the thrombus. So again, this is, for me, what I learned from Mercy was I used to try to do Mercy cases with the balloon guide catheter in the origin. And I'm convinced that if I would have put the balloon guide catheter at the skull base, I would have been a much better Mercy operator. So different case. So here we have a real, very redundant cervical carotid with almost a loop here in the mid-cervical. And I can tell you, you can see I've got my Berenstein in that loop. I could not straighten this out, and I have an M1 occlusion. So now my plan B, and again, it may be of your plan A, is, okay, I'm going to have to do some sort of intermediate catheter, because a balloon guide catheter in the origin here for me is not going to achieve flow reversal. So the internal carotid, if you just have the balloon in the origin of the internal and you inflate the balloon and you try to aspirate, it's very likely that the carotid will collapse on itself, and you're not going to actually achieve flow reversal. Whereas if you have the carotid, the balloon guide catheter up near the skull base, the carotid's not going to collapse then. You'll actually pull and reverse flow with that. So it's a very kind of a teaching point for another one for me is the balloon guide catheter, if your goal is flow reversal, it needs to be high up. So can I get the balloon guide catheter at the skull base? I could not on this case. So now I'm going to do either a primary aspiration or an intermediate. In this case, I ran an intermediate catheter up, deployed a stent retriever, did the TRAP technique, FAST technique, Solumbra technique, whatever your current acronym might be. So tandem lesions, again, many different ways to skin this cat. And I'll show you two different patients that we did. Critical stenosis with a distal embolus. This is one that we went ahead and ballooned it first. Did that to allow us to do the thrombectomy. You can see the M1 occlusion. Did the thrombectomy and then came back and stented after the fact. I'll tell you that that's kind of, we've trended away from that. This is an older case in that the most important thing on these patients with the tandem occlusions is the clot in the head. Almost always that's what's causing their stroke and their symptoms, not the occlusion in the neck. Meaning that if you can remove the M1 clot, they can have PCOM collateral flow then. They can have ACOM collateral flow, unless they truly have an isolated hemisphere. So our main focus now is get the clot out of the head and then determine, do we need to do something with the carotid or not? And again, many different ways to skin that cat. So this is that case, but an alternative way would be this with, again, another symptomatic critical carotid stenosis, subtotal occlusion, thrombus in the head. So we actually, and this is something one of my partners, Dr. Newman, published, is we'll put the, now I have 6 French guide sheath here. Now we just put an 8 French balloon guide catheter right in the common and cross through the occlusion with a microcatheter and a micro wire. So here's our microcatheter that we've gone through the occlusion up to the skull base and inject some contrast. And you can see there's a little bit of thrombus around the tip of the catheter, but then an M1 occlusion. So then we'll go ahead and advance the microcatheter beyond the occlusion and deploy a stent retriever, the longest one we have possible. So this is a 640 that tracks back from the occlusion back into the internal carotid. So we've now got our stent retriever deployed. We have our balloon guide catheter in the common. We'll take the microcatheter off. So now all we have is the stent retriever and the balloon guide catheter in the common. And the thought process is the stent retriever is tracking back all the way across the ICA terminus back into the ICA, kind of sort of acting like an EPD. So over the stent retriever wire, we'll advance a O1X rapid exchange balloon. For us, we use a Sterling, but a long one, like a 460. And so you can see it inflated here. Not only the occlusion or the stenosis is down here, but way up higher. And then as we're deflating that balloon, we'll advance the balloon guide catheter up to the skull base. So it's acting as a rail. So there's very, very little mismatch. So hopefully this video kind of shows that. Let's see. So the balloon was inflated across the stenosis, and as we're deflating the balloon, we're advancing the balloon guide catheter over it to use as a rail. And there's very little mismatch. Again, that's very easy to get that up there. I would say 9 out of 10 times it goes through whatever calcified lesion you have. So now you have the balloon guide catheter high up at the skull base. So we can now, you don't even need to inflate it because it's going to be occlusive of flow because of the stenosis. We can aspirate as we remove the thrombus. So now we've got a clean intracranial vasculature. we've got this balloon guide catheter up here at the tip of near the skull base. The trick here is you don't want to just pull the balloon guide catheter back, because the minute you hit the common with this, there's going to be restored flow, and you don't really know what is parallel to the balloon guide catheter in that area of internal carotid in the cervical ICA that may have had thrombus, may have plaque that's been dislodged with the angioplasty that you did. So prior to pulling that down, we will deploy an EPD. So you can see the balloon guide catheter here up near the skull base, the EPD being advanced up. We'll deploy the EPD and then back the balloon guide catheter down, so that if there is something that was parallel here, parallel to the balloon guide catheter, thrombus, plaque, whatever, the EPD offers some element of protection with that. And then we'll typically observe this for 3 to 5 minutes and determine, okay, is it going to stay open with just the angioplasty, or do we need to go ahead and just put a stent in and run, determine then, do we need any sort of antiplatelets on board? Did they get a TPA? That's a whole different argument. But it's kind of a nice way that takes advantage, again, if you're a stent retriever person, it takes advantage of that kind of wait time of having the stent retriever deployed, that you've deployed the stent retriever. Now, while we're waiting that 3 to 5 minutes, we can address the cervical carotid. So before, after. So just a couple other things that I'll share, and then we'll take some questions and see what other interesting cases we have. Vascular access, I'm sure this is not unique to Kentucky, but how many times have you all had this happen where you got access in the groin and you're like, okay, great, the iliac's occluded? This happens a lot. Kentucky, we like biscuits, we like gravy, we like cigarettes, we like sedentary lifestyle, so we have a lot of peripheral vascular disease. So this raises the question then of, do I need to do direct carotid punctures for some of these cases? Tortuous arch anatomy. Type 3 arches are standard of care in Kentucky. So again, raises this question of alternative access. And then we went over the tandem lesions. So classic M1 occlusion, left M1 occlusion. Here's the CTA. So we have a type 3 arch, type 4 arch if there was such a thing. And here's the left common carotid is going to make this turn here. So that's the left common carotid. So what are your options here? So for us, we used the SIMS 2 catheter, and we're able to get very good diagnostic images showing that once we got through this, the cervical and vasculature wasn't that bad. Had a classic M1, good peel collaterals. Despite having a Rosen wire, despite having a Amplatz wire, could not get a variety of balloon guide catheters to go beyond this. So cannot get a balloon guide catheter to track up there. So now I'm done with balloon guide catheters. Okay, that's not going to provide enough support, and I'm not going to be able to get it there. So what's the next question? Okay, do I need to start thinking about plan B? Yes. Can I do this through the groin with a aspiration or a stent retriever, a Solumbra kind of technique, or do I need to think about direct carotid puncture? So able to get a 6 French guide sheath here, almost assuredly this is a shuttle sheath. And then from there, able to run an intermediate catheter up intracranially, have a microcatheter injection beyond the thrombus, able to deploy a stent retriever and do an aspiration or a variety technique. But again, these are things that you don't encounter, is that the head may be the easiest part of the case. It may be that getting something to the head to pull the clot out becomes the challenge. And that's where you have to be familiar with a variety of different catheters. SIMS 2 catheters, H1N1 catheters. Be familiar with these different catheters because you may need them to get you access. You're familiar with the ways to achieve that case. Because, again, as we treat more and more patients and, extend to older patients and sicker patients and whatnot, these are going to be more common scenarios. Another one, again, this is a patient with a right MCA. The SIMS 2 catheter, this is the most I could get with it. It was just a brachial. It was just a innominate access. So you can see we're seeing, when we film the head, we're seeing the M1 occlusion, but we're also seeing the posterior circulation because we cannot get higher than this. This is the kind of, again, what this term was wanting to do. Total nightmare. So, again, direct carotid stick is last resort. So I'll tell you that this was probably 5 years ago, and this was a brachial stick. This is the Berenstein catheter. It's able to get a Berenstein catheter to come up through the subclavian, loop back down the innominate, and come up very high into the common carotid. When we inject the common carotid, though, we realize we've just now begun the problem. That was the Berenstein. This is now what the internal is doing. The internal is now looping back down and then back up into the head. So, again, zero chance of balloon guide catheter here. So, totally have aborted that aspect of it. Able to, again, brachial access, so a little bit bigger catheter. Able to get a flexible, this was an Aeroflex sheath to loop around into the common carotid. And then from there, able to get an intermediate catheter. So able to get the Aeroflex sheath to do that. And again, today's technology, today's intermediate catheters, it would be very easy to do this from a radial access and achieve all of this with a single intermediate catheter or like a Neuron Max sheath to go around all of this anatomy. And then through there, able to place an intermediate catheter up to the petrous carotid and do a thrombectomy stem retriever from there. So again, just thinking about these different techniques, you need to keep in mind there are different ways to skin a cat, different ways to fix a problem, but you need to kind of familiarize yourself with these different tools because Plan A works 80% of the time, but when it's not that 80% of the time, those cases very quickly turn into very complicated cases where you're looking at Plan B, Plan C, Plan D, and so you need to be prepared for that. Are there any questions about this kind of stuff? Or I think we're rolling along at a rapid pace. So again, we're here for you guys. Type us a question. Laugh at our struggles and say, hey, I did that case last week and it took me 10 minutes.
So I'm going to do this just based on pure stroke cases. I'd like to be able to have a little bit more back and forth with you guys, but we've got so many people on this webinar that it's going to be tough to do it. So if you have questions, just text them in there. But the first case is a very basic case. So 82-year-old female has stroke symptoms. The stroke neurologist calls you. And the first thing is to understand what do you want to know, right? I think a lot of people on this webinar are probably senior fellows and have taken these calls quite a bit, but there may be some junior people on there. There's some basic stuff that you want to know. So everyone just think to yourself, the guy calls you and all they'll tell you is, oh, this guy's, I think, having a stroke and we think he needs an angio and a thrombectomy. You're going to have to ask him like 4 or 5 things. So what are they in your mind? Just think for a few seconds. Yeah, MRS. Someone said that. That's a good one. I like that you're starting with MRS. That's great. Yeah, just less is more, right? Especially at 3 a.m. But yeah, MRS is right. I mean, if they're 82, and they're demented and in a nursing home and bedbound in diapers, I'm going to be a lot less excited. NIH, yes, good. People are answering here. NIH says stroke scale for sure. I'm just going to go through this here just so we can get a little bit faster here. So the biggest thing I care about is their time, right? Like we all know people's collaterals tend to fail over time and there's heterogeneity there. And at some point, we're going to get to the point where we're able to stratify really tightly on heterogeneity. But right now, we know at least that if they're under 6 hours, regardless of their heterogeneity as a population, they all do better with thrombectomy. So if they're under 6 hours versus over 6 hours, that's important. What does the CT show, right? It's got to be negative. What does CTA show? You want to see an LVO. You'd be amazed how many of these little boxes don't get checked. Oh, actually, they're 28 hours out. It's being transferred. Oh, the CTA shows that there's no actual LVO, and you literally will get called about this stuff. So, with the NIHs and the prior functional status that was mentioned. So let's suppose they say this: patient's 4.5 hours out, CTA shows an M1 occlusion, and their NIH score is 22. What else do you need to know? So someone wrote on here aspects, right? So if they're 4.5 hours out, aspects is of no use, right? Like, what are you going to do with the aspects is 3, right? And looks terrible, but they're 3 hours out. Are you going to tell them, I'm not going to do a thrombectomy on you? You can try that, right? But you've got level 1 evidence that didn't use aspects that patient's going to do much better with thrombectomy. So you're on pretty shaky ground ignoring that data for a non-con CT for aspects. So I would probably avoid that. And if they're after 6 hours, where you do care about that, then you're going to want advanced imaging. You're not going to go by aspects. You're going to want to get a CTP or an MRI to make that decision. So as much as people tend to talk about aspects, for me, I kind of tend to ignore it in my shop. If they're under 6 hours and they have an LVO, then they're getting a thrombectomy. Curtis, do you differ from that perspective?
Completely agree. Yeah, in 2020, you're pretty hard pressed to not treat somebody less than 6 hours out unless they truly have, a completed MCA on their non-contrast head CD. I
agree. And then let me see someone else here. Is that a question here? Is it right? Megan, how do I make the audience, the Q&A thing? The questions are super small. I've got all this nonsense in here about what time the thing was received and the priority, but the actual question is like really small. I don't know how to make it bigger. Anyway, I don't know if you can expand the question bar. Anyway, so what else you need to know? What I would argue with this, patient's 4.5 hours out, the CTA shows an M1 occlusion and the NIH of 22. What else you need to know is nothing. You need to know nothing. That patient goes to the lab and they get a thrombectomy 10 out of 10 times, right? Okay, so what's next, right? I had this beautiful picture here in between this slide and this slide of a can of Whoop ASS being opened. And of course, the legal people said, no way, Peterson, but I'm going to verbally put it in there. But so you see that and you're like, yeah, I'm going to kick some serious butt here. We're all going to bring in our EMS people and we're going to like show everyone how awesome we are. But I would argue, at least in the beginning, you got to think about this, right? Like, this is the time when you're going to be flailing all over the place unless you have a plan, right? And it's not just your own plan. There's one thing to be like, oh, I'm going to open this and then do this. But if you're not running the room right, it's going to be a mess, right? And I think that's something that doesn't really specifically get taught. People spend a lot of time talking about, oh, I'm going to open up this wire and this catheter, and I'm going to do this special thing. Do I stent first the brain or the neck? Who the hell cares if the tech is like fumbling around in another room trying to get something when you can't even get an access in the leg? I mean, you really have to decide who's in charge. How are you going to communicate with the room? How does the nurse get their stuff on time? Why are they getting this when you don't need it yet? The reason is because they haven't been told otherwise, right? So if the room is a mess and people are running around doing things in the wrong order, that is not their problem. That is your problem. You are in charge. This is your room, your case. You are the general, right? So that's what I tell the fellows. When you first get started and you're trying to get access in the leg and you've got the sheath with you, the first thing you need after that is your guide, right? So if the tech is back there opening up your stent retriever or opening up your aspiration guide, and then you're sitting there waiting for him to go get your regular guide sheath, that's not the tech's fault. That is your fault, right? It is your job to be like, I want this, and then I want this. And the way I do that, even on our shop where we do a ton of thrombectomy and everyone's super sophisticated on the lab side, people still get confused. They get worked up and they're opening up all sorts of crap that you don't need. So it is your job to be very specific about it. So the way I say this is, go get me this, and I look around, I'm like, all right, I need, the next thing in my head, I'm like, I need a flush bag for the leg, and you need a flush bag for this, and you need a flush bag for this, and I need the first system up there. I need my, in my case, we use Penumbra Select catheter and an Infinity, let's say, or a big, 088 system. So I don't need anything else until I get those two things, because I can't progress the case until I get those two things. So I just ask every 30 seconds, again and again and again, for the same thing. Where's my Infinity? Where is it? Guys, can I get the Infinity? It's coming, boss. Okay. Where's the Infinity ready? How about that flush bag? I just keep asking for the same two things over and over until I hear the words, it's open on the table. When it's open on the table, I say, great, and then I skip to the next thing I keep working, and I skip to the next thing I need after that, which is, I need my aspiration catheter. Where's my React? I need my React 72. Is it open? Oh, it's coming, boss. Where's that React? Where's that React? Just again and again and again and again. Nice, not yelling, but very focused and keeping them on the reservation, right? Okay. And then it helps there with regard to the plan is telling the tech up front. Like most shops, like Curtis, I'm sure, does the same thing every time for their regular M1 occlusion. They have the same setup they're going to do. Most of the techs are going to know that. It's still worth at least telling them. We're going to use a standard setup with this, this, and this. Oh, we're going to go femoral here. I want an 8 French teeth. I want this. In this case, I actually want a balloon guide. I want this. Like, there may be something separate, there may not, but 5 seconds of telling the tech, hey, George, what we're going to do today is this, while he's like getting the patient on the table, we'll save you 20 minutes down the road, right? We talked about this.
Just real quick,
yeah.
I mean, that is perfect. I mean, that is so great that you just said that, because we do cases at another hospital across town, and it's always a cluster, and our outcomes are completely different than at our main shop. And that's our fault, and we tell them that all the time, because it's not the actual thrombectomy that's the difference. It's the care beforehand, the preparation, and then afterwards. What is does the nurse have carding ready, or we have all these things ready? And so that is, I mean, he was talking about the J-wire earlier. This is what you want to remember is the success of the case is all in the preparation of what happens before and after. The thrombectomy is something that will become very natural for you and very controllable. It's the things that are outside of what you actually do that you need to be in charge of and make sure they get done.
Yep. Thanks, Curtis. And this is, I think, more of the same. Running the room, it's not easy. It's your job. People know their roles. It's your job to prioritize their activities. It's a mess. It's your fault. You're the general. And you know what I tell my fellows is this, like, in general, this stuff really isn't that hard, right? It's just a matter of communication and being ready. Know the exact places where they tend to get stuck, right? So the first thing, like, people run around doing stuff and they won't secure the patient, right? Like, I remember one time, this was 2 years ago, I think, we had a case where I came in, did the case. By the time I got to the patient, the fellow got an access on the table. And for some reason, I decided to actually scrub this time, and we did a thrombectomy, went fine. Patient did like amazing, like one of those Lazarus wake up on the table type things. I go in the next day to actually see my stroke patient for once because I want a little ego stroke. And I walk in the room, guy's perfect, NIH 0. And I get punched in the mouth by the family who says, how did my dad fall off the bed? And I'm like, excuse me, what do you mean fall off who? What are you talking about? And she's like, well, yeah, my dad, he's so good neurologically, he can talk now. And he told me that he was dropped on the floor by you guys. Turns out this lady's also an attorney. So what happened is the nurses from the ER rolled up and dropped off the patient in the room. There was 4 of them. The angio nurse that's coming from MR hadn't gotten there yet. The tech was late, didn't show up yet because it was 3 in the morning. The ER nurses, they put the patient on the table with the fellow, and the ER nurses say, oh, we're out of here, and they bounce. So now the tech there's no tech that's proper to the patient. The fellow is there with the neurology stroke resident. They don't put the belt on properly, and the guy bails and goes to ground. And the only thing preventing hitting him from the floor was this poor 2-pound neurology resident who somehow managed to like kind of catch the guy. But he fell off the bed. And just so everyone is aware, falling off the bed is a major problem, right, in the hospital. That is a blank check type of thing. Those are like never events classification things that the hospital is never allowed to have happen. So stuff like this really matters. So the first thing, make sure they're secure properly. In our shop, there's only one person who really knows how to do that well, and that's the tech. So whenever someone's like hustling along to get that room going and they're just going to load the patient themselves, all sorts of warning bells should go off. Those tables are extremely narrow. They are high. The patient is completely out of it. They're having a stroke. And it's a super easy way to have the patient fall off and make a beautiful case with a lot of happy endings go super south. All right, so secure the patient first, then prep. You can do that yourself. None of this fancy prep and shaving. Just slap on some betadine or a bunch of heavy cleanse or whatever you're going to use and just cover them up. It should take literally 2 seconds. Then the next order of things, in this case, we're using a sheath, then an 8 French float gate, then a 5 French select, and 3 flux lines. That's what you need. Don't ask for anything else, and keep repeating those things over and over and over again until you're done, right? And then you get the standard thrombectomy, and everyone, I think, knows how to manage that. Curtis did a really good job of showing how to do a standard balloon guide and standard retriever. This is a different case. 76-year-old true case stroke neurologist in town comes in with an acute onset of aphasia while he's eating dinner. He's 2 hours out. He's alert. He's moving everything full strength, no drift, but he's aphasic. NIH7. CTA is read as normal, no LVO. What's the plan for that? NIH7, CTA says no LVO, 2 hours out. I'll wait a couple seconds for some people to respond. So the big miss here is that it's really easy to miss an M2 on a CTA. It's actually easy to miss an M2 on a catheter angiogram, I would argue, at least with my eyes. So this guy isn't going to have an M1 because he's got an NH7, he's moving everything, right? He probably doesn't have that much cortex knocked off. But having a little M2 going right to speech is quite possible, and missing it on a crappy CTA is also pretty possible. Someone wrote here, maybe trifurcation, sure. That's true also. The bottom line is this guy absolutely needs a catheter angiogram. He has an M2 occlusion going to language until proven otherwise, right? Plus, he's a stroke neurologist. Like, not that anyone would want to be aphasic, but this guy literally was practicing yesterday. We want him practicing tomorrow if possible. So this is the angiogram. Let me see if I can show this audience view. Okay, so what do you guys see there? This should loop back and forth. Yeah, of course it doesn't. Oh, let me get back. One more time. So when I look at that, I'd say I can't see what the hell is going on there, right? It looks like everything's open, but we're concerned about something specific here, which is an M2. We know the M1 is open, right? So any monkey can see an M1 occlusion or carotid occlusion. Looking at a little M2 in the candelabra is not that easy, right? And particularly because if you know your anatomy, right, the way the MCAs work is they come up like this and they go out laterally, and then they wrap around a piece of brain to go posterior, right? And that wraparound point, that bend, is right usually where they tend to bifurcate. They wrap around the Lehman insula for the neurosurgeons in the room, and then they go this way. So on the AP, it's not always a nice, cozy wide. It sometimes will be like this, and you can't see it. So you have to have a system for sorting this problem out. This happens all the time. You need to be like immediately in your head, be like, is there an M2 yes or no question? And my algorithm for solving that is this: bam, 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 right? And the algorithm that I use for this is you need mag obliques in multiple different angles over that MCA bifurcation to prove to yourself that the M2 is open and there isn't any missing, right? Another clue that really helps, particularly with a big M2, is this, which is just look at the lateral, right? Oftentimes, at least I tend to get intoxicated by the AP because that's where your M1 tends to be. But if you look at the lateral, what's missing here, right? This is super obvious for the senior people, but for the junior people, it can often be not that easy because you see that the entire skull looks like it has blood vessels on it. But if you look carefully, you'll notice that when you look at these laterals and you're looking for something missing, you've got to make sure you subtract out in your mind the ACAs. The ACAs are not the frontal M2s. Those are different, right? So you really want to look for yourself, okay, what is going up here? Do I see any frontal M2? No, nothing. I see all these vessels up there. That's all ACA branch. There's no frontal M2 open. It's all out, right? So once you see that, then you'll realize that there's a little thing missing there, and you can go up and get after it. I had a bunch of more video and stuff in here, but it got cut, unfortunately, in the editing process. But the point here, at least, is to make sure you understand when you have a small branch like this and you see on the CTA that it possibly is an M2, the M1 is open, you have to have a good system of mag obliques and finding the M2. It's not that easy. All right. One last comment. Let me just see here. I think that they cut this, unfortunately. Yeah, they did. Okay, so one thing that's important to know is when you go up there for that M2, this is a technical point that we just lost because we don't have a good video here. The M2s, as I mentioned before, all the risk comes from going up and over the top of the M3 branch. So usually you have to get out that far with the microcatheter because you want your stent retriever to be on the other side of the clot, or at least mostly on the other side of it. So you can try to get lucky and J your wire and J it into the occluded M2. That's by far the best. But if you can't do that, you got to be really gentle trying to get through the clot with your wire that's straight, because that's where all the perfs happen, right? And then the second thing is once you get your microcatheter past it, and this is your catheter, you really want the stent to go up like this, stop, and then not move at all as you do a pure unsheath. And you'll see people screw this up all the time. When their catheter is here and they're pushing up their stent like this, you'll see the stent like snowplow out past it, right? Because they're pushing too hard. Or when they're trying to unsheath, the whole stent's falling backwards, right? Those are both technical errors by the doctor. You want to see the stent go up into one place and not move at all as you do a pure unsheath. In order to do that, you cannot just pin and unsheath, right? If you pin and unsheath, the whole system will fall back because of friction. So you do have to push a little bit while you're unsheathing to maintain that net zero position. If you screw it up and push too hard, the stent retriever will snowplow forward and you'll perf. And if you do it too little, the whole system falls back and you deploy the stent proximal to the clot, which is, of course, of no use. So be super, super anal about this. Make it your mission. When you're deploying the stent retriever, even if it doesn't really matter, make it perfect. Look at the distal marker of the stent and be like, I don't want that stent marker to move a millimeter. That is a perfect deployment, right? And when you see your boss screw it up and the thing's moving all over the place, don't say anything, obviously, but in your mind, just be like, yeah, that's sloppy. You want it to be perfect every time. And the reason for that is, number one, because it's good to be perfect, right? This job has low margins. You don't want to be on the other side of that. But the second reason is right now when it doesn't matter, this is the time to learn those skills. This is the exact same skill when you're deploying, like, let's say an Atlas or something that's an open cell stent where you have one shot to deploy it, and after that you cannot resheath it. That's not the time to be learning these skills and to misdeploying stents left and right. You want to be a ninja with these things now when you have a stent on a stick with a closed cell design and you can just rapidly redeploy it and resheath it. This is the time to really get anal about those techniques. It's a great technique for you to learn. All right. Oh, wow. Got hijacked here. Give me a second.
Yeah. While he's catching back up, that point too, again, I think most people, a lot of times these talks are preaching to the choir, and I think that most people on this conference would have treated that M2. But, the NIH doesn't matter on that patient. That's a disabling deficit for that patient. That's what matters. The NIH is terrible as far as predicting what a disability is, and you guys, I'm sure, are being taught that. But, don't let the NIH sway you. It's what is the disabling deficit that this patient has or may have.
Yeah, that's a great point. And it also matters the patient, right? Like, some people, a right arm may not matter that much for a little weakness. Some people it matters a lot. Okay, good. So actually, it looks like I did see the video here. So you can see here I've got a J wired. The wire is J going up into that occluded M2, right? That's what you want. So see how these bends, this wire is going around? This is super safe because the wire is J'd, right? I'm not going to hurt anybody with this. Sometimes, as I said, you get unlucky and you cannot J it into the M2 because you've got to steer the wire in there. But man, if you can get it to look like that, that is the safest way to do it by far. And then let's see, how do I get back out of my view here? There we go. So then you can see I'm clearly in the M2 branch that is closed because you can see the other inferior branch of the M2 below you. So you know you're in the right branch. do your micro run. And let's see here. Yeah, I don't have a video there, but you can see here this catheter. Did they see my my cursor, guys, or no? Do you see that, Curtis?
I do not.
No. Yeah. Okay. Anyway, so the tip of the microcatheter, you can see when you push your stent up, that's where you want it to go. You don't want it to go any further than that. Let me move this along here. Yeah, anyway, we've all seen that. Opens up, no problem. And then what you notice there is all the superior branches are open now. And it's not the ACA, those are all M2s. And then you can see on the M1, we're going to skip that because no one cares about the open normal angiogram. All right, next case. 85-year-old lady, left MSA syndrome with an NIH of 15, and then all of a sudden she starts improving and drops to an NIH of 0. So she's completely normal. CTA shows an M1 occlusion. What do you want to do with this? Anything else you want to know here for this? So the lady is now neurologically normal, but after the improvement, her CTA is done, and it shows that she's got a persistent M1 occlusion.
And while they're pondering that real quick, there's a question about thoughts about passing the clot without a microwire. Personally, I don't like to do that just because, again, I'm trying to deploy a stent retriever and I'm trying to get well beyond a thrombus. I know people do that a lot with aspiration technique, but that's not something that I personally do.
Yeah, someone else said here, what's the blood pressure, right, for this patient? Exactly, right? Yeah. You're talking about the blood pressure. So they tell you that, oh, yeah, blood pressure is 220, right? And this is her perfusion deficit.
Okay.
So that would make me a little bit nervous, right? I'm not sure what the right thing to do is there, but it's definitely something that is being evaluated now with trials. But in your mind, you're going to be asked this question a lot. And what my advice to you is to have the dialogue with your stroke neurologists and in your mind with your own institution at normal daylight hours. What you don't want to do is have this question unanswered and then have it back and forth for like 30 to 45 minutes at 3 a.m. via chat. That is just so painful. You don't want to do that. So just everyone should decide ahead of time, okay, it's 10 a.m., let's have some coffee and I'll sit down and talk about what are we going to do as an institution for patients that are NIH of 0 with a new acute LVO. Do we want to chase those or not, right? And there's some people that do chase them. I don't know what the right answer there is, but you do want to have that discussion because otherwise what will happen is at 3 in the morning, the neurologist will want to have a whole long discussion about it and start quoting data and papers, and you want to shoot yourself in the head. So you want to have that discussion, which is really important. You want to have that during normal daylight hours, and then at 3 o'clock in the morning, you can be like, no, dude, we talked about this. These people get a thrombectomy. Remember that? Done. There's no discussion. You just take them. Or, no, remember we talked about this? If they're NIH 0, we do not touch these patients. Unless they drop to an NIH of 4 or worse, we leave them alone. You want to just have all that ahead of time. There's lots of ways to argue this in either direction, and frankly, a trial is going to answer for us in the next year to 18 months. But have some sort of plan for that. Curtis, do you have any comment about how you like to handle persistent?
Two things. Number one, if their NIH is really 0 or 1 or 2 or whatever, you should be having that discussion with the patient. Because they can answer that question. And you can say, you've got this blood clot that's occluded right now. You're asymptomatic. We're worried you may decline. Do you want us to go try to do something now? Do you want us to watch you? Do you have any input on this? And, a lot of times patients will guide you with that. And so, don't forget that the patient, part of your informed consent is giving patients the option. And so let them help you with that decision. Now, certainly you can steer them certain directions based on what your beliefs are. But I think to not have that discussion with the patient and not give them the option is part of it. And then, what are the chances that an 85-year-old is going to be able to sustain systolic blood pressures of 220, 210, 180, whatever it may be to maintain those Peel collaterals? Her heart's going to give out. So to me, I think we all, anticipate that trials are going to tell us that patients with low NIH and M1 occlusions do poorly without intervention. But right now, that's still something that I agree wholeheartedly. Clarify with your institution what your plan is with those patients, because they are going to come in. You are going to see them.
Yeah, that's a good point. And the other thing is that you really have to know how good your stroke neurologists are, because we're lucky at our place. We have 7 or 8 vascular trained stroke neurologists that are very good, and they can give a lot of really interesting thoughts, and they can manage these patients, and they have good ideas. But in the community, oftentimes you don't get that, right? Often you're the stroke guy, and that is an extremely painful thing to deal with, because you get these questions where there's like kind of a quasi-ICAD case and there's fluctuating symptoms, and you're like, man, I don't really know what is really going on here. And there's kind of an anatomical lesion, and it's just tough to sort that out. And you ask the neurologist, well, what do you think? And the guy's like, oh, I just do EEGs all day long. I'm just covering the ER, man. Aren't you the stroke guy that we just hired to solve this? Like, I'm hanging up now. Like, that is the conversation you're going to have. And that's tough. When you look at jobs, you always want to think about that. Like, what kind of support do I have, particularly for the stroke neurologists that are on the thread here that are doing thrombectomy. It is very nice to have a rock star stroke neurology crew that can back you up and help you work through these things. And again, if you don't have that, that's all more the reason to have a pretty good idea of how you want to handle these kind of index challenge cases that are on the margins. And you really reach out to your network, your fellowship director and everything, be like, how do you handle this? And come to your own conclusions. But again, you don't want to be hemming and hawing too much at 3 in the morning. You got to do it during normal business hours. Another case, this is one I'm going to bust through just because Curtis showed this already. 67-year-old man, NIH at 20, 3 hours out, CTH is M1 occlusion, and then you run up and do an angiogram, you see this. There's a lot of different ways to do this. I don't have a dog in this fight. Just pick one and just stick to it, because then that way when you know someone's coming up with a carotid tandem occlusion, you're like, okay, my algorithm for that is this, and you just go bang, 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 and you bust it out. You don't want a lot of hemming and hawing. The way I like to do it is to dodder up a big 088 guide, clean the brain, and then on the way out, look at it and see what's left. And if I can get away with just leaving it, then I do. And then I do an ENDART the next day or a stent once I know they haven't bled. And if I think it's AC and it's not going to look good, then I drop a stent at the end because I'm worried about them closing down. But there's a lot of regional people that do it the opposite. Just whatever reason you want, just come up with a thing and stick with it. And the last last one's a very easy case. It's not a long discussion. This is a lady that had an 8-year-old, a potential basilar, had a thalamic syndrome per the stroke neurologist. Again, this is why it's helpful to have the neurologist help. I wouldn't even really know what a thalamic syndrome really is, but they can sit there and be like, oh yeah, this is what this lady looks like she has. But the CTA shows no LVO. Basilar's open. Mm-hmm. All right, so this is another one of those pattern recognition things that I don't want anybody who's listening here to leave without recognizing this and not making the mistakes that we did. So the CTA shows no LVO. The neurologist saying, well, the patient's still symptomatic. They've got this thalamic syndrome. What are you worried about here? The thing that you need to do is you need to do an angio on this patient, right? Because we did not. We said, well, there's no LVO. And what the patient had was a small top of the basilar clot. P1s were open, but what was not open were the thalamoperforators off of the basilar apex. And what happened is this guy lost both his bithalamic strokes and he got devastated. So just in your mind, when you hear, oh, there's some basilar question and the basilar's open, and the neurologist saying, look, it sounds like they've got a thalamic syndrome, but I don't see an LVO, you need to do an angio to rule out a clot at the top of the basilar, and if there is one there, clean it out. Make sense?
Along those lines, the angio thing, it is extremely rare that barring some groin or radial complication, that I wish I hadn't done an angiogram on someone. Remember, it's the dynamic study. It's showing you how fast blood flow is. Is it slow here? Is it fast there? MRAs, CTAs, these things are a snapshot in time. They're not really telling you that. So if there's a clinical mismatch between the imaging and the patient, your threshold to do a diagnostic angiogram should be very low.
Yeah, I agree with that. It's tough to argue whenever there's a question what to do. The only thing that I would say for that is we didn't talk too much about this, but ICAD in the setting of an acute new insult is a very dicey thing to sort out, right? Because the perfusion is going to be a mess because they've got chronic hypoperfusion, and you're not going to really be able to interpret the new deficit. And they've got all this underlying ICAD there that's going to be tough to fix anatomically. You're not just going to be able to stent retriever or aspirate that out. They've got ICAD up there. And I think having a good neurologist to kind of figure out, okay, well, what is going on here? What did this patient have before? Like, oh, this patient actually presented 3 months ago with symptomatic M1 ICAD, and we had decided to hold off and treat with medical therapy, and now they're worse. Is there new deficit from an LVO, and they've got a whole bunch of brain that's out, in which case you got to go up there and open it up? Or is this that they've just done a single embolic event, and they actually don't have a huge perfusion deficit, and the vessel may be open, and this is a Sampras bucket. This is someone who failed Sampras. You wait a week for them to get over the stroke, and then you angioplasty and stent that M1. Those are totally different things. And if you dive in there and try to, be Rambo and do a stent retriever on an ICAD patient, it's not going to work. And you may not need to. They may not have active ischemia. But if you try to do a CT perfusion on that patient to answer the question, they're going to have a perfusion deficit, and that's just how they live all the time. If you image them a week before their stroke symptoms that they're presenting now with, and with the CT perfusion, they're going to have a perfusion deficit then. So that doesn't help you. So it's really easy to find yourself pushed all the way down the rabbit hole for doing a thrombectomy on somebody that has underlying ICAD, and it may not be what they need. So again, thinking through these types of things, having a good team to talk through them with you is really, really helpful. The last point I had here was just about for BAS. This is an old slide deck. My apologies, this one slide. But for the basilar stuff, you often can't get an 088 all the way up there. I don't use NeuroMax anymore, but whatever you do use, it's usually pretty reasonable to use if you're going femoral to do a short system. You don't want to put a 90 up there because you're going to run out of room, right? Because you're not going to be able to put that thing in the vert. Usually you're going to have to park it at the vert origin. That means the whole system's hanging out of the body, and then your aspiration catheter doesn't fit because you don't have enough room to get all the way up to the top of the PCAs. Just know that for a normal femoral system, go shorter, not longer, because you're not going to often be able to get it all the way up into the cervical vert of V2 unless they've got a huge dominant vert. And the last comment here is just about what happens if it isn't opening, right? Like, you do whatever you like to do first. You're a balloon guy and a stent retriever guy, or an aspiration guy, whatever. You do your first thing, it doesn't work. You repeat the first thing, maybe you do it a third time, and now you're like, okay, this is not working. What is the next step here? You got to just know, like, okay, if that doesn't work, I immediately just bump to this, to this, to this. So in our shop, everybody gets an 088 aspiration, an 088 catheter, then 2 or 3 passes of adapt, no microwire, just the snake technique. You just jam it up there with nothing. And if it doesn't open up, then we just go right for the stent retriever and we do a Salumbar technique. All right. But you have to just know an algorithm so that when you're on your kind of second pass, you should already be asking the tech, hey, go get the solitaire, get it in the room, go give me a sync, like, get all the stuff you want in the room, like moving that stuff along. So as soon as you start seeing that, we're going to have to escalate here. The stuff's ready to go, and they're not hoping it down to IR to buy it, to look for the extra stuff just because you waited the last second to ask about it. And that's it. This is just about stroke stuff. Have 5 good available people that do endo that you trust. You can call them, text them on a moment's notice, and they answer and you believe them. Not that easy to find people like that, but when you do find them, just put them on your phone. Even now, I text people all the time, even like about standard stroke stuff. I mean, it's just, I have no shame. Even in the middle of a stroke, I would be like,
today.
Absolutely.
I texted someone today.
You got 2 seconds. I just perfed. Do I use glue? Do I coil this off? I mean, there's so many people that are available. Like, the best thing to do also, you can just text like 5 at once, and whoever answers first, you get your answer. I mean, there really is no reason to be doing this in a vacuum. And there's so many people being trained. There's so many hospitals that want people, that having guys out in the community totally solo without any backup, without anybody to tell them that they've wandered way off the reservation is super common. So as the guy that's coming out for you guys and gals, don't be that person. Like, have your Rolodex of people, and when you do something, be like, yeah, I checked with 4 different people that are a lot smarter than me, and they all said what I was doing is reasonable. Like, do that for a good few years before you wean yourself off them. And if you're like me, you'll find yourself never have been weaned off of them. And that's it until we get to the, this is the next one. Megan, that's it for stroke stuff, I think. Do we want to do some questions, or how do you want to structure it?
Yeah, looks like there's a question in the Q&A box.
Yeah.
That just came up. What about thrombectomy?
Yeah, just like I said, it's not you're not removing clot there much, right? If you have a 70% narrowing and they've got an overlying LVO, you're going to remove 30% and you're left with this crappy ICAD. So then you can try to do a stent retriever. The answer to your question, I would start with a stent retriever. You're not going to get an aspiration catheter through a 70% ICAD, but whatever you're left with is probably not going to look great. So then you have to have a low threshold for angioplasty and stenting. I don't know, Curtis, you want to chime in there?
Yeah, I think that, know what your plan is, know that you're going to try a stent retriever, you're going to try aspiration, whatever it may be. And then if if it's a patient that you're like, okay, I really think this is ICAD now, then we'll try just a balloon angioplasty, suboptimal, a 2 millimeter balloon, see if that restores flow to where we think we can get them, then through the next several days. We try not to stent initially if possible.
Yeah, the other thing, there's a question here about, do you have a cutoff core size on advanced imaging? That's a great question, and as you probably know, is unanswered at this point. The main thing to know is twofold. Number one, that the trials that looked at this, even though they included up to, I think it was like 70 cc's or something to be included, if you look at who actually got randomized, the vast majority of the people had significantly smaller cores than that. So you can't just say, oh, we're going to randomize up to 70 because that's what the data shows. That's not what the data showed, actually. So in our internal shop, we actually went through this, and as I mentioned, we had a conference where all the neurologists and the interventionists sat down, and we discussed all the data, and we landed on a specific number that I think it was like 40 or something. If they're above 40, then we'll probably hold off because there's no data to show that those patients can do okay yet. And if it's below that, then we would take them. As you know, there's a ton of large core and all this stuff trials going on now. So again, that question is going to be answered pretty soon. But sometimes, frankly, it also happens to do with the patient. If there's like a 30-year-old, guy who's normal, who's 3 hours out, who happens to have unlucky collaterals and has a large core, I mean, at least in my hands, he's going to get a thrombectomy. Curtis, you have a comment about that?
Yeah. I think it very much at that point you're looking at, okay, am I going for a rank and shift as opposed to trying to say 0 to 2 really? And then it's, basically what's the patient's baseline MRS, what's their potential for recovery? The 80-year-old left MCA with 85 cc core infarct is going to do significantly worse than the 30-year-old with a right MCA and an 85 cc core infarct. So questions come into play like, okay, can I save a hemicraniectomy? Can I, if I do a thrombectomy? Can I take a Rankin 5 and make them a Rankin 3? So it really, then a lot of patient, the individual patient comes into play. So I think it's very hard to standardize a number and say above this number we're not going to treat or below this number we are going to treat, because that's, those are good guidelines to start with, but then it ultimately comes down to, the individual patient.
The other question here is about BGC versus 088. It says standard. I assume they mean, what do you want as your first choice? We started off doing BGC and solitaire for everybody, and we were a little bit late on the aspiration stuff. And but when I started doing ADAPT and realized how much faster it was in some group of patients, and despite the pretty reasonable retrospective data that a balloon guide does help, I started getting impatient with the amount of the time and the inflexibility of doing it. So I switched over to just throwing up an 088 and the aspiration catheter and doing not even with a microsystem, going straight. So right now, at least our first choice is an 088 system, an 070 or 072 aspiration catheter, and an 035 glide wire. That's it. So we put the 088 here. We put the aspiration, do a roadmap through the aspiration catheter hanging out on the other side of the wire. So the 035 glide wire is pulled back about 10 centimeters or so for support. And then you just jam the whole thing up in a snake technique and get it into the M1, take out your 035 and just aspirate directly. If you can't get it up there that way, then we open up a microsystem and use that to get up there. Some of my fellows really swear by the balloon guide, and they like to do the same thing I just described, but they'll do this with a balloon guide there. That's how we've evolved as far as what our first choice is. It sounds like, Curtis, you're a BGC guy also.
Yeah, we still, again, old school, so it's hard. We have that down. That's our rhythm. So, we prep the balloon guide catheter in the patient. We don't prep them outside. So during that 5 minutes that the stent retriever is deployed, or 3 minutes, we'll prep the balloon during that. So, it really, our average case is 15 minutes. I average just straight aspiration cases probably 10. It's probably a few minutes more to do it that way. But that's just our flow of, how we know we're going to approach it. And I think that's the key is, again, your plan A, you want to be very successful and you want to be very proficient with it. So whatever it may be, just make sure that you're getting that technique. And if you realize that, hey, I'm not getting, 80%, 70% Tiki 2B3, then look and see, okay, is there something I'm doing technically wrong? Should I be trying some other technique? That I think that's the key, is that really in today's day and age, you should be getting, 70, 80% at least Tiki 2B flow.
Yeah, I agree with that. And the next question is about what about distal thrombectomy? I think there are really two cases there, and Curtis, chime in here if I'm wrong. It's really an ACA clot, like an A3 clot, and someone who's got a clear hemiplegia in the leg. And then the second one would be speech, right? Because both of those times the patient's going to have a relatively low NIH. They're going to have a relatively low amount of brain to save, but they're both significantly disabling deficits. As you all know, those are all trials that are being looked at. For me, I go after those knowing that your risk of perfing is higher. So I would try to get up there with like one of those smaller aspiration catheters, and if I couldn't, then I would just go up with either a small stent retriever or something. But I would go after them. I don't know what your sense is, Curtis, on those.
Yeah, absolutely. I mean, again, I think that the definition of ELVO changes. What we called ELVO 5 years ago is different than what we call ELVO now, and now the concept of the medium-sized vessel occlusions. Understand we're going to be treating the more distally. So the question is, do you want to, be a front runner with that, or do you want to be a late adapter to it? But those patients are going to get treated, and we're going to have devices that make that easier and techniques that make that easier. But certainly now we'll chase, up to pericallosals, and beyond, and chase M3s and chase PCAs based on the patient's disability.
The other one question here is if you have a large DWI restriction on someone with an LVO and a large penumbra, still within 6 hours, would you do a thrombectomy? So if you have a large DWI restriction and large penumbra, that by definition is that question about cutoff on core size. So we already kind of talked about that one. So again, if they have a large DWI restriction, the core size is high, 60, 70, 80 cc's, then the answer is no. What aspiration catheter do you use for distal thrombectomy? We usually use the 3 Max, just because it's the only thing that's long enough to get way out there. There's a bunch of other ones coming out now, I think. I don't know. You probably don't even do aspiration for distal things. So
we use stent retrievers out into the M3 and A3 pretty routinely.
Yeah, I agree. That's what we tend to do too. And then any other questions here? These other ones are duplicates here.
The unclear neuro exam being due to intoxication. CTA, CT perfusion.
I think that's a follow-up of the question before, where they say there's an unclear neuro exam, and I think they're just clarifying that. So I think we're done with most of the content here. Is there anything else, guys, on the of the fellows? Any other types of questions you guys want to talk about or have us to chime in on here before we sign off? This is a good time
to the operator, if there's anybody live on any live questions, can we bridge them in?
Excuse me, ma'am, we have no question at this time. Please continue.
Okay, thank you. All right, you guys. Well, if there are no further questions in the chat box, then I just want to thank both Dr. Given and Dr. Peterson for presenting today, and thank you all for your engaging questions and discussions. If there are any questions regarding the program that didn't get answered today, we can be in contact with you and get those answered. And for any of you who are not aware, we do have one additional session for fellows education that will be next week on May 20th. Which Dr. Given and Dr. Peterson will cover flow diversion cases with pipelines. So we hope you can join in for that session as well. So thank you all for joining today, and hope everyone has a great afternoon. Thanks everyone.
Guys.
Hey, thank you.